Greetings, my name is Kalyn. I'm one of the PGY1 pharmacy residents at the Atlanta VA this year. I'm excited to share with you the results of my resident research project that focus on the role of pharmacists in treating alcohol use disorder and specifically in how we can increase prescribing rates. I, as well as my co-investigators, have nothing to disclose about today's project. So what is alcohol use disorder? The National Institute on Alcohol Abuse and Alcoholism defines it as a chronic relapsing brain disorder characterized by an impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequences. Despite the growing number of alcohol use disorder diagnoses, unfortunately, only 7.7% of those who are diagnosed actually receive treatment within 12 months of their diagnosis. AUD affects millions of Americans, and specifically it heavily affects our veterans, as 40% of veterans will screen positive for AUD at some point in their lives. And unfortunately, those veterans who are diagnosed are actually at a higher risk of death of all causes than those who are not, which just further highlights the need for increased clinical intervention, potential opportunities for pharmacists, and they definitely inspired the work behind this project. So the VA is actually actively working to address the growing number of AUD diagnoses in our veterans. It currently has an automated dashboard tool that identifies patients who have an encounter diagnosis for AUD without an active prescription. In order to help guide clinicians in their decisions and improve prescribing rates, pharmacists have begun specifically using the output measure on this dashboard by reviewing eligible patients and making pharmacotherapy recommendations based on specific information and appropriateness. You can actually see a screenshot of the dashboard here on your screen, and you can see that the Atlanta VA healthcare system has thousands of patients who have been identified that can potentially be eligible for AUD pharmacotherapy. And these patients were the target of this project. So in addition to the safety dashboard tool, this project also focused on using audit C-scores. So pharmacotherapy is not actually indicated in all patients with AUD. Utilizing the patient's audit C-score can actually help the clinician into assessing the patient's need for AUD pharmacotherapy. The audit C is a questionnaire that providers can give to patients to identify their severity risk of drinking. Audit C scores that are greater than or equal to 6 indicate that a brief intervention with pharmacotherapy and psychosocial interventions are recommended for recovery. Therefore, patients with an audit C that were less than 6 were excluded from the study due to pharmacotherapy not being recommended in these patients and us focusing on improving prescribing rates. The purpose of this project was to assess the impact of pharmacist-led interventions on improving prescribing rates of alcohol use disorder pharmacotherapy. And this was in order to create opportunity for quality improvement for our institution. The primary objective was to determine the percentage of patients that received evidence-based treatment for alcohol use disorder before and after implementation of the pharmacist-led chart reviews. So essentially, pharmacists began reviewing charts using the dashboard tool and the output metric, and we looked retrospectively at these chart reviews to see if their recommendations were accepted. This project was a retrospective chart review that occurred between October 2020 and March 2021. It was performed at a single center and focused on identifying quality assurance opportunities for our health system. As far as the methods, this was an IRB exempted project. It included patients 18 years of age or older. They had to be identified by the dashboard tool. They had to have an audit C-score of greater than or equal to 6 that was performed within the last year. And as the goal of this initiative was to determine the pharmacist's impact on increased prescribing rates, patients who were already prescribed AUD pharmacotherapy were excluded. So all pharmacists that reviewed charts and provided recommendations for pharmacotherapy did so using a standardized note template. They did this just to create standardization, not only for themselves, but for the providers reading the recommendations. This note template included the factors you can see here listed on your screen. When doing these chart reviews, if the patients were eligible and appropriate, pharmacists recommended either a acamprosate, naltrexone oral tablets, naltrexone intramuscular injection, disulfiram, or topiramate. Even though topiramate is not FDA approved for AUD pharmacotherapy, it was included on the dashboard metric tool because it is actually included as first-line treatment in the Department of Defense clinical practice guidelines. Pharmacists made recommendations individually for patients made on patient-specific factors and prescribing information. Here listed are the data points that were included for every patient and that were recorded when available and applicable. Displayed on the screen are the demographics of the patients reviewed. The overwhelming majority of the patient population reviewed were African American males. There were a variety of audit Z-scores included in the project. A total of 65 patients were reviewed and provided recommendations. Here's actually the breakdown, with approximately 86% being recommended naltrexone oral tablets. However, out of 65 total recommendations, only 3 were accepted. 2 patients were started on naltrexone oral tablets and 1 on topiramate. There was a multiple number of reasons for the remaining 62 patients who were provided recommendations that were not accepted. The most common reason being that there was no documented offer by the provider despite patient contact. There are various limitations for this study that potentially impacted the outcome and effectiveness. Small sample size was one, as well as limited documentation. There was also limited time between initial and post-intervention review. This could be depending on the patient's scheduled appointments, so there may not have been an opportunity for the provider to make this intervention after the chart review recommendation was made. There was also no direct patient contact made, which could have been an impact because it's really important to involve patients in their treatment, as ideal management of AUD not only involves pharmacotherapy, but it also involves psychosocial interventions. In the future, our institutions should seek educational opportunities for providers and patients, as well as improve our collaborative efforts, and ultimately adapt this chart review initiative, as this does not seem to be the most effective way of improving prescribing rates for AUD pharmacotherapy. I'd like to acknowledge the contributions of my project advisors. And the self-assessment question is, what audit Z-scores indicate that the patient may benefit from pharmacotherapy-assisted treatment? The answer is scores 6 through 12. Here are my references, and thank you for listening.